CVS Part 1 Case 19.
A 34-year-old man with no prior cardiac history presents to the emergency department with severe substernal chest pain radiating to his jaw and left arm began 25 minutes ago. He is agitated, diaphoretic, repeatedly states he feels like he is going to die. His friends reports the patient smoked crack cocaine approximately 45 minutes prior to the symptom onset. Vital signs includes BP 198/112, heart rate 138 per minute, respiratory rate 26, SpO2 is 95% on room air. Physical examination shows mydriasis, tremulousness, diaphoresis, no murmurs and clear lungs. ECG shows ST elevation in lead 2, 3 and AVF, QTC prolongation. Initial drop I is mildly elevated. He is given sublingual nitroglycerin, but chest pain persists. The nurse administers IV metoprolol, after which the patient suddenly develops worsening chest pain. BP rises to 220/118. The repeat ECG shows increased ST elevation. Emergency coronary angiography demonstrates diffuse coronary vasospasm, superimposed thrombus in proximal RCA. Which of the following is the most appropriate next step in management? Option A, IV esmolol infusion to control tachycardia. Option B, immediate fibrinolytic therapy with alteplase. Option C, IV lorazepam followed by nitrates and antithrombotic therapy. Option D, emergent CABG for multivessel vasospasm. Option E, IV phenylephrine to improve coronary perfusion.
This is a case of cocaine-induced myocardial infarction. It's a confusing case as it engages multiple mixed concepts. ST elevated MI, severe hypertension, cocaine use, coronary vasospasm with thrombosis and worsening with beta blocker. Now, to understand the pathophysiology of cocaine-induced MI, there are four key features. First is alpha adrenergic vasospasm, which leads to coronary vasoconstriction and reduced coronary blood flow. Second is the prothrombotic state, where there is increased fibrinogen and thrombus formation. The third is increased central sympathetic outflow, which leads to tachycardia, hypertension and increased myocardial oxygen demand. Fourth is endothelial dysfunction, that is impaired release of nitric oxide and hence predominance of vasoconstriction. Now, this case gets worsened with cardioselective beta blocker. Why it's happening? Because when we give IV metoprolol, then the beta 1 receptors are blocked, which leads to unopposed action of the alpha receptors. So, alpha-led vasoconstriction further leads to worsening of coronary vasospasm, and there is very much reduced blood supply in the coronary arteries. Now, coming to the treatment part of this case, the first line treatment is benzodiazepines, as it decreases the central nervous system sympathetic outflow, and hence it also leads to a decrease in the release of catecholamines, which helps in relieving vasospasm, coronary vasospasm and reducing the tachycardia and hypertension. Now, the second line treatment is with antiplatelet drugs, the third line treatment is with nitroglycerin, and the fourth line is heparin and clopidogrel. If after giving 4 line of drugs we still get ST elevated MI, then we go for PCI. Now, coming to the option exclusions.
Option A is IV esmolol infusion to control tachycardia.
So, as we have discussed that the beta blockers worsen the situation, this is not the correct option.
Option B, immediate fibrinolytic therapy with alteplase.
Immediate fibrinolytic therapy is not given. As we have discussed the 4 lines of therapy, they are followed.
Option C, IV lorazepam followed by nitrates and antithrombotic therapy.
This is the correct option, as benzodiazepines are the first line of treatment.
Option D, emergent CABG for multivessel vasospasm.
Emergent CABG is not done here. This is the wrong statement.
Option E, IV phenylephrine to improve coronary perfusion.
IV phenylephrine will further make the situation much worse, as it will lead to alpha adrenergic vasoconstriction. Now, coming to the detailed therapeutic algorithm of cocaine-induced MI and the comparison of typical STEMI with cocaine-induced MI, we can refer to the ebook.
Search Edumedex on Instagram and YouTube to start your journey today.